So first of all, I have to thank Dr. P.N. Ranjan, whom first time I met in 1995 in American Academy of Neurology. And since then, our friendship has been growing strong. I have attended most of these meetings which he holds. So I was telling him during the lunch, I've got a huge staying power. And they are getting stronger day by day. And I welcome all of you. Post-lunch is always difficult, but we'll make it. So should closure of PFO be recommended treatment and standard care of patients in patients with ESUS? Now, you know, every coin has two sides. So one side of the coin I'm going to talk about, and the other side of the coin Padma is going to talk about. But you must know that the coin is one. Coins are not two. Okay? Now, first you have to know what is ESUS. It's a new term. It basically means embolic stroke of uncertain source. It means we don't know where from the source of the embolus is. So therefore, usually in the heart, atrial fibrillation is a common source, or the clot is a common source. But in these patients, it should be normal, right? Then carotid artery disease, there is usually source of plaques here, but their plaques should not be there. Carotid arteries should be clean, okay? And third thing is intracranial arteries also should not show any obstruction. And fourth thing is there should be no penetrating artery disease. So therefore, the definition of embolic source of uncertain source is that heart should be normal by 2D echo, carotid arteries and intracranial arteries should be less than 50% stenosis, which means they should be normal, and it should be a non-lacunar infarct. So, and preferably it should be cortical, because usually embolic strokes are cortical. So therefore, it is a stroke which is probably embolic, but we don't know where from the embolus has come. That is ESUS. Previously, it used to be called cryptogenic stroke. And now more and more, the term is embolic stroke of uncertain source. And for diagnosis of this, the recommended strategy is that you should have a brain MRI so that you document that there's actually a stroke, and ECG should not show atrial fibrillation, and 2D echo should be normal, and MRA extra as well as intracranial should be normal, and cardiac monitoring for at least 24 hours should not show any arrhythmia which can cause stroke like atrial fibrillation. Now, there are many causes and many suggested causes of ESUS, but the three big are paroxysmal atrial fibrillation, aortic arch atherosclerosis, and patent foramen ovale. And paroxysmal atrial fibrillation is detected only by long-term monitoring, sometimes as long as 6 months by loop recorders. And aortic arch athero and patent foramen ovale is detected by transesophageal echocardiography. Okay, now the difference between these three is that the patent foramen ovale is a cause of stroke in the young. So what is definition of young? It has been changing over the course of time. It used to be 40, then it became 45, then it became 50, and now it is 55. Okay, so we have hope. Many of us are young here. So that is about ESUS, embolic stroke of uncertain source. Now, what is this PFO? PFO, as you know, it is a defect in the septum between the two atrium. And usually it gets closed. It's important for fetal circulation, but as soon as the child is born, usually it gets closed in 75% of the people. But in 25% of the people, it remains like that throughout their life, 1 in 4. So therefore, in this hall at this time, there must be at least 15-20 people who have got a PFO, and they don't know about it. But it's usually asymptomatic. Usually, it doesn't create any problem. But if you take this group of people with ESUS, there it is more than 25%. There it has been found to be 40%. But all the 40% will not lead to stroke. Out of that 40%, a small proportion leads to stroke, 4%, 5%, 6%. So therefore, some of the PFOs are dangerous. Some of the PFOs can cause stroke, but most of them do not. We have to understand that. Now, which are the PFOs which have a potential of causing a stroke? For that, a score has been validated, which is called a ROPE score. So ROPE score says that if there is no history of hypertension, if there is no diabetes, if there is no prior stroke, if patient doesn't have smoking, then he gets a point for each, which means it is, and he has a stroke. He has a stroke but no prior stroke. So today he comes with a stroke, with no hypertension, no diabetes, no prior stroke. And if he is young, then he gets more points. So if you are young and if you have no other risk factor, okay, then you can score as much as 10. So if you have a score of 10, that means probably it is your PFO alone which is giving rise to stroke. On the other hand, if you have hypertension, diabetes, you are a smoker, you have had a stroke, then we are not sure. So ROPE score is one score by which you can say that probably his PFO is causing a stroke. That's as far as the ROPE score, as far as the clinical risk factor profile is concerned. But the other thing which has been validated is the anatomy of the parent foramen ovale. There are many studies which have shown that if the size of the PFO is big, then there are more chances of causing a paradoxical embolism. Because in most of the benign ones, it is from left to right. The pressure in the left atrium is more, it's from left to right. But when it becomes paradoxical, it comes from right to left. That sometimes happens when we sneeze or when there's a Valsalva maneuver. And particularly if the patient has an underlying coagulopathy or a DVT, then there is a right to left. And it has been found that if the size of the shunt is big, then there are more chances. And also, if the septum itself is deviated in an aneurysmal way, that's called atrial septal aneurysm. And if the aneurysm is significant, which means more than 10 millimeters, then that is also a predictor of the embologenicity of the PFO. So therefore, based on these, you make a best guess that probably this PFO is responsible for this patient's stroke. Now, which is better? Once you know that there's a PFO, and once you know that this is the PFO which is probably caused him stroke, which is better? Should we close it by some endovascular technique or just medical treatment? And that is the debate of this afternoon. Now let us look at the available literature. What does the literature say? There were 3 earlier studies which were done after 2010. One was Closure 1, one was PC, and one was Respect. And all of them had about 2 years of follow-up. And all of them did not show a clear benefit. But please note the term. They did not show a clear benefit, which means they did not get an absolute majority, but they got a majority. They showed benefit, but it was not a clear benefit, which means p-value was not significant. Several meta-analyses have come over the course of years, and I'm showing you one of them. And as you can see, this is the Closure study, and this is the device, and this is the medical therapy. And you can see that the hazard ratio is 0.75, which means it showed benefit. It's less than 1. It showed benefit, but p-value was not significant. So they said that there is no statistical difference, but there was a trend towards the device. Okay, same was true about PC trial, same was true about Respect trial. Respect trial also, they had about 2 years of follow-up, 2.5 years of follow-up, and they found that they are better, but it is not significant. And now look at the side effects. People have been concerned only with the morbidity and the side effect of the device, obviously, for obvious reasons. And what they found is that when they collect the data of all these 3 trials, which I have talked to you about, what they found is that there are procedural complications, but there was much more bleeding in the Closure device trials, and there was more of atrial fibrillation when you did the mechanical endovascular intervention compared to when you did only the medical treatment. But surprisingly, when they took away the first trial away, when they took away the Closure trial away, and they did the data analysis only of the next 2 trials, they found that the complications became very less. As you can see, when you do all the 3 trials, then the atrial fibrillation was in 1.49%. But when they did only these 2 trials, they found it was only in 0.93%. Similarly, bleeding, when they did all 3, they found 0.45%. And when they did only these 2, they found 0.13%. So therefore, it seems there was something wrong with that first trial. There was something wrong, which was causing, bad results and more complications. So what was that? What was the problem with the Closure trial? It's like one fish spoils the whole pond. One apple spoils the whole basket. Closure trial just clouded the whole data. Because they found that there were unacceptable complications by this device. It was called Star Flex device. And they also found that their inclusion criteria of taking the patients were not very stringent. They did not go by the size of the shunt. They did not go by the presence of septum. They did not were so strict about ruling out other mechanisms of stroke. They took a lot of TIAs. They took Lachner strokes. Now, you know, TIA also itself, sometimes you can take seizures also as a TIA. Sometimes you can take even non-organic things. So stringent criteria were not there. And of course, because this was the first trial, there's always a learning curve. Even in our hospitals also, when a new batch of resident joins, for first 6 months, there are complications. We have seen it. So there was a learning curve. The second and subsequent trial, the results became better, right? Because it is the same people who do the trials again. They learn in the first trial, in the second trial, they become better. So because of these unacceptable side effects, this StarFlex trial was withdrawn from the market. And new devices came, which were more sophisticated, like Amplatzer PFO occluder, like CardioSeal, like Gore Helix Septal, and all of them have been used in the subsequent trials. And in all of them, the perforation rates and the AFib rates and the bleeding rates are much less. They are there, but much less compared to StarFlex. So in October 2016, the FDA of America approved the Amplatzer PFO occluder device for patients 18 to 16 years old with PFO and cryptogenic stroke. So they approved, even though it's not still in the guidelines of America, but the device was approved for using it. So therefore, in summary, the meta-analysis of the trials, earlier 3 trials in 2017, clearly show that the PFO closure is superior to medical therapy for recurrent ischemic stroke. But if the analysis is restricted to the trials in which only the StarFlex is taken away and Amplatzer PFO occluder is used, then the benefit is even greater. But let me emphasize, even though the benefit is there, it still was not good enough. It was not statistically significant. As Padma's favorite term is the word game changer. I'm borrowing it from you. So the game changer of this became new trials, which came in the last year. 2 new randomized controlled trials of PFO closure versus medical therapy were published, CLOSE and REDUCE. And these trials used stricter enrollment criteria than the 3 previous trials. So they made sure that nobody crosses age of 60. They made sure that it is PFO alone. They made sure that all mechanisms are ruled out. They did not take TIAs. They took only strokes which were proved on the MRI. So, and they used better devices, and the interventionalists were more experienced. So in closed trial, all of them have almost same number of patients, ranging from 250 to 600 and 700, leave that. So after a follow-up of 5.3 years, subjects who underwent PFO closure had a lower risk of recurrent stroke than those maintained on antiplatelet therapy alone. So the data from closed trial suggests that for every 20 closed patients, 1 stroke is avoided at 5 years. That's called number needed to treat. That's how statisticians talk. What is the NNT? So NNT was for 20 interventions, 1 stroke is avoided at 5 years. And another trial was reduced trial. And in reduced trial also, patients were same 18 to 59. They had a cryptogenic stroke within 6 months. And the data from reduced trial suggested that for every 28 intervened, 1 stroke was avoided at 2 years. So they were clearly positive trials with statistical significance. In both these trials, reduce and close, PFO closure was associated with a higher risk of atrial fibrillation. That is there. That complication did not go significantly down, but it was found that most of the times it was self-limited, many times it was transient, and a lot of times it actually did not lead to further strokes, but it was there. So close and reduce were likely positive because of stricter enrollment criteria, leading to the inclusion of subjects whose presenting symptoms were secondary to PFO rather than another etiology. Now, interestingly, one of the earlier failed trials, which was called RESPECT trial, they also, even though it had failed initially, they did not stop it. They went on following these patients. So initial data which had come was only about 2.1 years, but they went on for 5 years. And surprisingly, they found that at the end of 5 years, the surgical arm, the intervention arm, did better than the medical arm, which means people who were in the medical arm continued to get strokes. Whereas over the course of ensuing years, 3rd year, 4th year, whereas the people in the intervention arm got few strokes. So long follow-up. And as you can see here, the at first year, the number needed to treat to avoid one stroke was 250 in RESPECT trial. By second year, it was 70, and by 5 years, it was only 23. So as you have a long follow-up, your results became better. And other thing which RESPECT trial showed is that if you have got a substantial shunt size, the benefit favors device significantly. And if you have got an atrial septal aneurysm, again, the presence of the septal aneurysm favors the device significantly. So these two also are significant predictors of the outcome of the device, the size of the shunt and the size of the atrial septal aneurysm. So this is the summary of these 5 randomized trials. If you see, this is all what has been done: closure trial, PC trial, RESPECT trial, closed trial, reduced trial. And in most of them, in closed trial, there is statistical significance. And in others also, there is in the last 3 trials, there is statistical significance. There's one more trial which has been done after that, but that has also shown the same. I think it's called defense trial. So this is the lessons which have been learned from individual trials. RESPECT trial showed that the follow-up has to be long. Most of the trials have a follow-up of 1 year, 2 year, 3 year. No, we have to go beyond. We have to go 5. Then we'll know the real picture. Reduced trial showed that the device safety is very important. So they used the cardioform septal occluder, and complications were less. And the closed trial showed that the case selection is very important. So there were lessons from each of these trials. Now, this is a real issue, complications. But if you look at carefully, complications have been coming down. Complications depends upon the experience of the intervening endovascular interventionalists. And this is this statement is from the American Heart Association, which says that percutaneous closure procedures are generally quite safe when performed by experienced operators. That is true about any procedure, whether it's a bypass surgery or whether it's a AVM occlusion. Depends also, you have to choose the interventionist very carefully. Okay, in fact, people go by their audit. What is their response? So we are assuming that the person who is doing the job is experienced and he is good at it. Serious complications are exceedingly rare, and some of these are considered to be attributed to specific design flaws in the earlier generation devices. And I specifically looked at the atrial fibrillation, and it was found that the number of patients in whom atrial fibrillation was detected was relatively low. It's often self-limited complication of PFO closure that may occur more frequently in elderly patients and those who were treated with the Starflex device. So even though fibrillation is an issue, but it is not such a big issue. See, complications happen. Complications happen in any procedure. But I think at this point in time, they are, if you balance them with the benefit, probably one can take those complications. Aeroplanes crash. Other day, one Indonesian aeroplane crashed with 189 passengers. Still, I took a flight this morning and came here. It didn't crash, but planes can crash. So this is from Stroke Journal, American Heart Association, which is clearly endorsing new data support patent foramen ovale closure after stroke. And this is from NEJM. NEJM normally doesn't have a kind word for anybody, but even NEJM by Alan Roper writes the editorial tipping point for patent foramen ovale closure. Now, American Heart Society guidelines as of now, they are old, they are outdated. I think they are going to update it. As of now, they have not updated as this procedure in their guidelines, but Canadian stroke guidelines have already endorsed PFO closure. This is Canadian stroke guidelines, and they clearly say that for carefully selected patients with a recent ischemic stroke attributed to a PFO, PFO device closure plus long-term antiplatelet therapy is recommended over long-term antithrombotic therapy alone, provided all the following criteria are met. That is 18 to 60 years and the stroke is because, and this is level of evidence A. Okay, because 3 trials have supported it. TPA came into guideline based on only 1 trial, and here we have got 3 trials. So Canadian Stroke Association has already endorsed it. These are BMG guidelines, and BMG guidelines clearly, I looked at it yesterday evening, it clearly says we recommend PFO closure followed by antiplatelet therapy over antiplatelet therapy alone in a carefully selected patient. And this is up to date. Up to date is something which we always keep in our pocket and immediately consult it. And up-to-date says approach to treatment. Closure of a PFO may prevent paradoxical embolism and thereby reduce the risk of recurrent stroke. Evidence from randomized controlled trials on balance now suggests that PFO closure is effective in reducing the risk of recurrent stroke for the select patients with cryptogenic stroke. So friends, this is my summary after going through this subject. One is that PFO is a rare cause, no doubt about it, in individuals less than 55 years when no other cause is found. It's a rare cause. Recurrence also is rare, but it's there. The causality is more between stroke and PFO if no other stroke risk is found. So that is very important for us to rule out. I would choose large PFOs with atrial septal aneurysm more than 10 millimeters for closure. But I would also choose the person who has to do it very carefully. I would look at his record. I would look what device he is using. Recent studies have found a significant reduction in risk of recurrence if you use these devices followed by antiplatelet agents. Complications are there, but they have markedly reduced over time. AF is there, but it is usually self-limited. And one thing we should know about PFO, that it's a cause of stroke in the young. There's a difference between a stroke in a 20-year-old boy and an 80-year-old man. He has got a whole life ahead of him. So the stakes are very high. So I will definitely offer to him. I will not force him. You know, when I used to ask my son, please get a glass of water for me, he would look at me and say, are you forcing me? I said, no, I'm not forcing you. He said, okay, then I will get it. So I will not force them, but I will give them definitely this option. But as I said in the beginning, every coin has two sides. Dr. Padma will give you the other side of the coin, and the coin is only one. Thank you.